Good afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment, Shout, Texas, presented by BeWell. Please note that we are recording these sessions for later distribution. Please note that anything listed in the chat does not appear in the recording. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, click on the speech bubble icon on navigation bar at the bottom of your window. To all the BeWell Texas providers, please make sure that you identify yourselves during this session, or if you're joining via phone, please email your phone number and name to bwelltx@tx@yathiska.edu. Some housekeeping: please stay muted unless you're speaking. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6. We also encourage you to unmute and speak, especially during the discussion portion of our session. We want to hear from you, as many of you as possible, so please keep your comments brief to allow time for others to speak up. Or if you prefer, you can use the chat feature to share comments and questions. Please note that no protected health information is allowed in either the chat or our discussions. If you'd like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. Towards the end of the session, the Shout Texas Echo team will send out a link to an evaluation survey. All participants filling out the survey will be entered into a raffle for a $30 Walmart gift card. Our didactic today is on treating opioid use disorders in the context of fentanyl use, and will be presented by Dr. John Weems. Following that, we will discuss a case presented by Dr. Anupama Kapadia. We will start with introductions, followed by didactics, BeWell program announcements, case presentation, and open discussion. Thank you all again for joining today's Echo. In the spirit of all teach and all learn, we encourage you all to share your experiences, questions, and insights in today's conversation. And with that, we will do some introductions. Dr. Weems.
Hey everybody, I'm John Weems. I'm an internal medicine doc and addiction medicine specialist here at Community Care FQHC and part of the Shout Hub team at Dell Internal Medicine.
Thank you so much for joining us. Dr. Moriartis.
Dr. Chris Moriartis, hospitalist, and I work at Dell Medical School, and I'm part of the Shout team.
Thank you so much. Dr. Kapadia.
Hi, everyone. My name is Anu Kapadia. I am a primary care physician at Community Care, one of FQHCs in Austin, and I just joined our addiction medicine team outpatient. So I'm excited to be here.
Thank you. Welcome. Alana.
Hi, good afternoon, everyone. I'm Alana Bolton. I'm a program manager at Dell Medical School and the director of Shout Texas. Thank you all for being here.
Thank you so much. And I would like to introduce our new Echo manager at CSTAT by BeWell Texas, Julie Parrish. Could you please introduce yourself?
Hey everyone, I'm Julie Parrish.
You're muted, Julie.
There we go. I had muted it one place and not the other. Sorry about that. As Shreya mentioned, I am the new Echo manager here with BeWell and with CSTAT. Just a little background, I am a chemical dependency counselor and licensed rehabilitation counselor here in the state. Super excited to be here with you all. Thanks for having me.
Thank you so much for joining us. And with that, we will move on to our didactics for today. Dr. Weems, you can take it away when you're ready.
Great. Shreya, can you see my screen there?
Yes, perfect.
Okay, perfect. All right, everybody. Today we're talking about starting buprenorphine in the context of fentanyl use and in our fentanyl era here in Texas and across the U.S. And, you know, before we started, we just had a patient who was successfully, for the organizer, successfully transferred by EMS to the hospital. And I was just walking in, and when you walk in our clinic, you walk past our memorial wall for patients who have passed away too early. And it's this really beautiful butterfly garden maintained by some of our amazing MAs and front desk folks. And it's just a reminder of sort of what we're up against, what our patients are up against, and the incredible grief our patients have and that we carry ourselves. And it also reminded me that, you know, part of how we get through it here at our outpatient clinic is we have each other, and we get to walk with our patients as best we can through what they're going through, and then help carry each other through what is a very, very challenging and important time to do this work. And, you know, the topic today is kind of a narrow clinical one about starting buprenorphine, but that context of community is really important here too. You know, frankly, with fentanyl changing so fast and other drug adulterants changing so fast, you know, the timeline of science of getting us like good scientific studies on this stuff is not keeping up with how fast we need to change things to serve our patients. And in the face of that uncertainty, I think reaching out to each other and having a community of practice like this, again, to walk with each other and carry each other through it, to learn together, is a very meaningful thing to be a part of. So in the context, that's a context I hope we can embark on a conversation that's kind of narrow about starting buprenorphine. Okay, and I have no disclosures. So our objectives are to talk about the evolving clinical challenges of starting bup in the setting of high potency synthetic opioids like fentanyl, to recognize modifications to standard bup and start strategies, and then to talk about potential risks and benefits of novel bup start strategies like rapid high dose, low dose, and overlapping low dose initiation strategies. This is a flashback to our Shout Echo session in April, just reviewing some pharmacologic characteristics of fentanyls. So we're talking about a high potency substance, and in the street supply, it has a very unpredictable composition. And it's highly lipophilic, which leads to a couple of clinically meaningful effects. One is rapid onset, so it crosses the blood-brain barrier and causes overdose within minutes for some. Rapid off, which leads to changing injection practices. And then with chronic use, fentanyls are stored in the fat and slowly release, which is called a reservoir effect. And clinically, that leads to long variable washout periods in tough buprenorphine starts. So we still, in the majority of cases, are doing standard buprenorphine starts, where, and again, this is from the X-waiver training, where you have in green full agonist opioids, and typically street fentanyls that our patients are taking. And when you see the stop sign there, that's to represent a patient stops taking heroin or fentanyl, whatever they happen to be taking. They go into withdrawal, which is the dotted line there. And the way we do a traditional buprenorphine start is to wait until they're in moderate withdrawal. So starting buprenorphine increases the overall state of agonism, and patients feel better. So that is the principle of cessation strategies, or strategies where you stop the opioid you're transitioning off of. And the challenge with fentanyl, sort of building on that last slide, is that we don't know about the slope of that green line, because it might be that green line and somebody might go through withdrawal in the anticipated sort of 12 to 24 hours, or it might look like this, where patients are in our care 2 to 3 days and still not having the kind of withdrawal one would expect given their pattern of use. Or it could be just somewhere in between. And there's very significant inter-patient variability in terms of the symptoms and timing of the washout period. And all of that matters because what we want to avoid and what often traumatizes our patients is precipitated withdrawal. And precipitated withdrawal, again, is the early initiation of a sufficient dose of buprenorphine to lower the total agonist mu-opioid effect a patient is experiencing and causing rapid severe withdrawal symptoms. And that's due to buprenorphine's partial agonism and high receptor affinity. And there's a lot of other great Shout talks that are still all available on YouTube to review this pharmacology if anybody needs to kind of catch up on that. This is the Shout Texas buprenorphine standard initiation quick start guide that's available at that QR code. And this has been updated through the years, and I want everybody on this call to be familiar with this and where it is. And if you have a buddy who's practicing in another hospital and doing bupe for the first time for their patients, or just need something you can reach to remind yourself of how to get this started in the hospital, that's the goal of this, is that you have a one-pager you can use to guide your practice in the moment. And it walks you through, identifying appropriate patients, counseling patients on what to expect, building rapport and trust, treating symptoms, and then getting to what you see on your right, which is this administration protocol, which is an update of the standard buprenorphine start protocol, which is to wait until there's moderate withdrawal, which is observed by the CAL scale, introducing 2 to 4 milligrams of buprenorphine and repeating until there's a significant reduction in the opioid withdrawal symptoms, consolidating that and eventually titrating is as needed in the subsequent days. So this is the standard bupe start. This is what I think many of us probably do in our clinical practice. In the majority of patients, this is still a strategy we can use. It is the most evidence-based approach to starting buprenorphine and getting our patients the opportunity to take a med that will cut their risk of dying in half. So when we're thinking about the tools we have, this is still one to reach for, probably first in most cases. These are some of the modifications that have been made. One is just to wait longer, acknowledging that washout period is likely to be longer, so to wait for a higher CAL score. A more aggressive use of adjunctive medications to help get patients through that washout period. More frequent dosing for a higher total daily dose of bupe. And if there's ongoing withdrawal, to consider higher buprenorphine doses. And then considering increased supports, like bringing, in the hospitalized setting, inviting loved ones to help somebody through if they're going through a tough withdrawal period, including peer recovery support specialists and other experts in the experience of this difficult initiation stabilization phase. And then the outpatient setting, often we're thinking about higher levels of care like residential treatment as modifications to the standard bupe start. Some of the clinical experiences I'm guessing a lot of folks on this call have had, and we've talked about in some of our other shout venues, is like something like this. This is a case from last week. A patient's taking blues or M30 pressed fentanyl pills every day. Their goal is to get back on bupe. They waited 18 hours. They're seen in clinic. They have a CAL score of 13. And they take the standard bupe initiation dose of 4 milligrams and have rapid, evident precipitated opioid withdrawal. And I think the conclusion it's led a lot of our patients to, and even us ourselves, is that Suboxone doesn't work with fentanyl. And one of the goals of today is to sort of take this insight built on experience of, like, I waited a day and a half to start bupe and got sick. What else can I do? And say, hey, we're a little bit in a world of options that are emerging, and we want everybody to be familiar with some resources that can help inform our clinical practice and give our patients options. Two big documents came out just in the last couple of months that we want everybody to be aware of. The first on your left there, the PCSS. And if anybody doesn't know the PCSS, man, it is great. It is a treasure trove of really excellent addiction medicine educational content, and still ongoing roundtables and discussions of current topics that come up in our practice. And experts from PCSS kind of got together, the Brain Trust, and came out with these practice-based guidelines in May. It's not a clinical practice guideline in the formal sense, because frankly, the strength of evidence isn't there in the process. That wasn't the process. It's more just expert researchers and clinicians that are part of this community putting out, some guidance for clinicians. And you'll see on the right there, this was published in the Journal of Addiction Medicine a couple of weeks ago. This is a expert guidance from ASAM, the American Society of Addiction Medicine, on starting buprenorphine in the context of fentanyl. And again, this is expert guidance. And in the case of the ASAM review, it's based on a narrative lit review that's described in the methods. And so a little bit, a lot of overlap in the guidance between these two documents. They're both really good reads, and the QR code can take you to PCSS one there. So we at the Shout Hub team use these two documents to help develop this new alternative buprenorphine initiation strategies one-pager. And it's similar to the standard start guide we have, and will be a part of our Shout resources that come out later this fall. And for the rest of the time, we're kind of going to walk through how to use this guide. And to sort of orient you overall. So on your left, page 1, you'll see there's 3 different columns for 3 different alternative start strategies. Those 2 under the gray are the cessation administration strategies. So it's the same, like you're stopping fentanyls or whatever the other opioid is, and you're waiting a period of time before taking a strategy to start bup. The 2 are the rapid high dose or macrodose protocol and or low dose protocol. And then the third one there, the third column you see is the crossover administration strategy. It's also called microdosing, also called low dose buprenorphine with ongoing full agonist. There's a bunch of different names, but it is shaded white rather than gray because it is different. You continue the full agonist while doing a microdose or a crossover protocol. So there's your orientation on page 1. We'll kind of discuss those. And then on page 2, what you have is concretely, this is what it can look like when the rubber hits the road. Before describing the washout period, looking at treatment day 1 in terms of the timing of the dose and the dose, whether or not to continue full agonist. And we'll review all of these over the next couple of minutes. In between those is what we hope is some very helpful kind of foundational principles for approaching this problem with our patients. And first, it's about shared decision-making. And I think we all come from that place, but it's a really good reminder that we're making this decision to help somebody make a decision about their body and to celebrate that autonomy in our shared decision-making discussions. And then to again point out, the second box there points out the variability, the significant variability. And so time-based protocols are unlikely to work. And they don't sort of recognize that our patients are dealing with a ton of trauma because of all of the loss and because of their experiences attempting to start bup in the past. The final thing is comfort meds there. So some of my heroes, Laura Keogh says the kick pack is back, baby. So we, in all of these strategies, we are much more encouraging teams to be more liberal about the use of comfort medications. And just to be clear, so comfort meds as a means of treating opioid use disorder is not the standard care. And the risk benefit of using comfort meds when you're trying to get a patient on bup or methadone didn't favor the use of these medicines aggressively because there are risks such as polypharmacy and sedation. But in the context of fentanyl, when we have a lot of patients with a very hard time getting on bup, that risk-benefit ratio changes. You can't get on the medicine that's going to cut your risk of dying in half, then the risk-benefit ratio for each of these interventions changes significantly. And patients have given a lot of feedback that these medicines really do help to endure these prolonged washout periods and even into early stabilization once buprenorphine's been initiated. And then a big thing, flexibility and a backup plan. So if plan A doesn't work, we got to listen to our patients and walk with them to figure out what plan B can be if there's unforeseen complications. All right, so now we'll step through the 3 options. The first is rapid high dose bup. This was developed in EMS and in the ER. The idea is to see moderate withdrawal, at least one objective sign on your exam, and then start an initial dose that's between 8 and 24 milligrams and rapidly increase it. The benefits are it's fast, simple, and likely to quickly treat withdrawal. And what you'll see here is a list of publications which show that they're not randomized controlled trials. There's some limitations to them. And precipitated opioid withdrawal with the strategy is very, very rare. So what we have is a observational set of data that lends rapid high dose some evidence. So getting back to sort of how this shows up in the alternative start guide. So that's where you'll find it all the way on the left, rapid high dose, best suited for folks who for whom the standard initiation wasn't successful. There's high opioid tolerance and there's time constraints. So in the Bridge, California report, the studies reported on, patients were out of the ER in 2 hours. So this takes 2 hours to get done. The pros are you quickly reach a therapeutic dose and have a potentially shorter washout period. The cons is it requires bedside availability to monitor for precipitated withdrawal, which again is rare, or sedation. And remember, you're doing that Cal score to observe evidence of withdrawal, implying tolerance. And so again, screening out folks who are unlikely, who would be sedated by a higher dose of bup. Hope that makes sense. Other considerations, this might be the best way to get people to XR bup based on some smaller studies. And then one consideration, what they did in Bridge, California was use buprenorphine monoproduct. And part of the idea is you're using a lot of buprenorphine. And so, that 8 and 2, the 2 milligrams of naloxone in each one of those 8 milligram strips or tablets really starts to add up when you're at these higher doses. And so it's reasonable to consider initiation, at least with buprenorphine monoproduct. And then here is the table of timing, which again points out that you're starting with 8 to 24 and rapidly getting somebody to therapeutic doses. And so by day 2, by day 1, and on day 1, you're already close to your stabilization, potentially your maintenance dose. So that's rapid high dose. Option 2, and this was just in the PCSS, so you won't find this in the ACAM guidance. But the experts at PCSS and some of our patients have described sort of a modification of the traditional start that's a low dose. And what that means concretely is to give 1 to 2 milligrams of buprenorphine after a significant washout period in the same way that's depicted here in this iteration on the X-ray graph. This is best suited for patients who were not successful with a standard start, and rapid high dose is undesired or inappropriate. This might not be, and for those with uncomplicated medical or mental health conditions. It's very similar to the standard protocol. That's the biggest pro here, is that it's closest to the thing that has the most evidence and probably clinicians are most comfortable with, and potentially patients are most comfortable with. It gives a longer period to recognize and treat precipitated withdrawal, if that's what you think you're dealing with. The downside is a longer washout period and a lower starting dose, so it takes longer to get to that therapeutic dose. And patients struggle with that. That's the low dose start. The language gets confusing here, y'all. So we load overlap strategies, crossover strategies, microdosing strategies. That bucket is often called low dose as well. So that lent some sort of confusing language here, but on this guide and in the PCSS guidance, low dose means a cessation strategy. You're stopping the other stuff and you're starting on buprenorphine, albeit at a relatively lower dose. And this is what it can look like. So what you see, as you go into the third column there, treatment day 1, you're giving 1 milligram of buprenorphine every 2 hours. And again, the theory here is it's a low dose, so you're unlikely to have the antagonist effects of buprenorphine, but the agonism of bup, and specifically the biased agonism of bup, is thought to be resetting some of the post-synaptic effects of opioids and sort of getting people's tolerance down, even though it's a small dose. So that's the theory with this one. Our patients are comfortable with it at times, and it's a good one to have in your back pocket, the low dose cessation strategy. All right, in the final few minutes here, we're going to talk about the crossover or microdose, and this is a figure we've seen before from the Ghosh review in 2019, where on the top you see the molecular mechanism of precipitated opioid withdrawal, where you have in gold the full opioid agonist totally occupying receptors, and then with a high enough dose of buprenorphine, there's a rapid reduction in the net opioid effect as those bup molecules kick out the full agonist, and 20 minutes later people feel very badly. Whereas with crossover microdose start strategies, here called bridging at the molecular level, the full agonist is maintained throughout the initiation in sufficient dose of the full agonist to meet the patient's tolerance, while buprenorphine is gradually introduced, gradually displaces the full agonist off the opioid receptor. And this takes place over many, many days. So that's the idea. We'll skip that. And this is where to find it again on the SHOUT resource that Alana has led the development of. So it's all the way on your right. So this is best suited for care teams with increased capacity for education support. So this is great for inpatient settings. We're in the SHOUT echo. This is worth considering adding to your practice. For patients who are averse to withdrawal symptoms or breakthrough pain, this is a great strategy. So if patients are telling you straight, I cannot tolerate withdrawal to start bupe, but I want to get I want to have the advantages of being on bupe, this can be a very effective strategy. It's also well suited for those with concomitant pain who are going to have dynamic full opioid agonist needs throughout their hospitalizations. The pros include minimal withdrawal symptoms, suitable for pre, peri, and post-op patients, and there's no washout period. The downside is it takes long. It takes a long time. That's the main one. Considerations: you have to keep the agonist at a stable dose. In our outpatient world, it's sort of a separate discussion. If anybody's curious about that, please reach out. It's tougher here. In the inpatient world, where we can prescribe full agonist opioids for patients in opioid withdrawal under federal law, this is a great place to stabilize and maintain your full agonist dose while crossing over onto buprenorphine with this protocol. This is what it can look like. So this is notably a much longer table than the other ones because you're starting with these very small doses, like 0.5 milligrams day 1, 0.5 BID. There's several different protocols that are in the literature. This one is very straightforward. It would require conversations with pharmacy to implement because there is splitting of sublingual doses, or in the inpatient setting, potentially you could use other formulations like buccal transdermal or IV buprenorphine to do a similar protocol to this. All right, and we'll end with a couple of counseling take-homes. So just reminder stuff we always already do, but worth reminding ourselves to let the patient guide careful planning. We're going for a standard start, high dose, low dose, overlap. And to remind patients we will get through this together, to invite supports and reassure. And don't forget the comfort meds, because like Laura says, the cake pack is back. And that's all I got.
Thank you so much, Dr. Weems. This was a wonderful presentation and lots of good information. I'm going to open up the floor for questions. Lindsay.
Yeah, I don't know if you talked about it, and I just wasn't paying attention, but have you heard of low dosing for ketamine to get people like as a quicker way of getting people off of opiates?
It's a really great point. So both of the documents, like PCSS1 and ASAM, are like, we need to know more about ketamine. Definitely. So it's like one of the priority areas for research. One of our hub partners, Nick Christian, published and spoke recently about the role of ketamine in precipitated opioid withdrawal. So folks who have run into trouble because the bupe was administered too high a dose too soon. And ketamine is very, very helpful for precipitated opioid withdrawal. And Lindsay, I like how you're thinking about it. I think there's not enough research yet, and we will keep our eyes open for when there's kind of guidance documents coming out about how to use ketamine. In the end, it's harder to manage those risks or help our patients manage those risks in the outpatient world. But man, when we're inpatient, it's a great option. I wish I had more for you, but I hope it's somewhat reassuring nationally. People really want to know. They really want to know.
Yeah, thank you.
Thank you. Dr. Miramontes.
Yeah, I have a more of a comment than a question. So we use clonidine in the bridge between the washout, but I just want to caution people in Texas. It's hot here. Clonidine lowers blood pressure. They can get hypotensive. So if you are going to use clonidine, you have to really push the education. Eat salty foods, drink plenty of fluids, avoid caffeine and alcohol, and get up slowly. So we use it for the first day, 24 hours on the washout period. Most of my patients are fentanyl patients. And then the next day, we're able to use bupe. But I think clonidine is a great bridge med, but we are in Texas. We have to be careful. We have to give good instructions to our patients so they don't stand up and pass out from orthostatic hypotension.
Love that. Thank you. It's so helpful. I think the other factor in our area of polysubstance use and thinking about clonidine is stimulants. So psychostimulants, particularly methamphetamine, drive a higher sympathetic tone, and people have higher blood pressure and they tolerate that clonidine. If you stop the meth and it washes out at the same time you're stopping the opioids, that tolerance for clonidine or other meds that drop blood pressure, that's going to drop off too. So it's tough to have that conversation in the moment with patients, but those are the folks we kind of keep a closer eye on if they're going to be a total stopping everything, and versus those who potentially might continue.
So the other thing I was going to caution, and this has come up in my world, and we have to say, dude, you got to stop everything, not just the fentanyl. You can't use meth. You can't use the fentanyl. You can't do this. I'll give you meds, but you can't use. And the reason why is because, especially in San Antonio, the meth has fentanyl. The bars is fentanyl. The fentanyl is fentanyl. Everything has fentanyl. So if we're going to try and wash them out, they have to stop using everything. And so we give them a take-home pack. I like that. The kick pack. I like that. We give them a kick pack to take. We see them in the afternoon, and then they have a kick pack for the evening time. And then we dose them in the morning with bupe. And that usually is enough of a washout. But just wanted to bring that up. Two things, hypotension, and also they got to stop using everything because everything has fentanyl in it.
Thank you. And I see a question here on chat from Dr. Chen. With comfort meds with clonidine, how do you typically write for it? And do you ever write for a clonidine patch? You're muted, Dr. Weems.
Great question. Because we're in SHOUT and focusing on inpatient world, I'm just going to extend Dr. Miramontes' point to the inpatient world. And I just noticed Dr. Walker there. So one of the, what up? So any wisdom you have would be, if you got it, but patients show up with polysubstance use and they go into multiple different withdrawal syndromes. And if we don't pick up on the sort of late presenting benzo withdrawal, if we're not keeping our radars up for xylazine withdrawal, we're going to miss an opportunity to treat those withdrawal symptoms and keep patients engaged in care. And the other one that is a little more, our systems aren't built around, but it's critically important, is the meth withdrawal. I mean, our patients are they're dysphoric. It can present a number of different ways, and without getting into it, if it's leaving somebody pacing around their hospital room and talking about leaving the whole time, you should really consider the risks and benefits of something to help with that, potentially like a low-dose benzodiazepine. All right, I threw out benzos there, Dr. Walker. What do you think?
Oh, I was going to say that the clonidine answer, like clonidine patches or whatever, I mean, we definitely use them. I think one thing to just bear in mind is that the patch has real slow onset. So it takes like 72 hours to kick in. So you slap it on and it's like, they're great actually augmenting alcohol withdrawal because it takes about 3 days, which is kind of when you're peaking in alcohol withdrawal, like slap some patches on arms is an outpatient protocol that like Stanford and people do. But I think that's the only piece is like, you don't get as much bang for your buck with the patch right then. If they can't hold anything down there in the hospital and you want them to be on that and they're not so bad as to need a Precedex drip, then a clonidine patch is a nice augmenter, you know, just to take the edge off. It's certainly not going to hurt, but you get about 25% of the patch, I think, the first day, and it's sort of between 50 and 75 day 2, and then it's up to 100% day 3 is my learning from our pharmacists. So that's just the caveat, but we use a lot of clonidine. It really helps.
Thank you so much. And with that, we will move on to our announcements. Thank you, Keto. CSTAT for substance use training and telementoring provides high-quality education to healthcare providers. CSTAT makes evidence-based practices available to addiction specialists in Texas and US with sessions like the one you're attending today. For more information, please visit bveltexas.org. Next slide. To claim your CME credits, you must text by tonight, midnight. Please text attend 100-942-50 to 844-502-1338 to record your attendance. Next slide. Save the date. We are starting 2 brand new echoes this fall. The first one is the Recovery Science Echo, which will be held on the 3rd Wednesdays of every month. We are starting on Wednesday, September 20th at 12 noon. Please watch out for registration links. Next slide. The second new echo we are starting is the Behavioral Health Echo, which will be held on the last Friday of every month. We are starting on Friday, September 29th. To learn more, please visit our website at cstat.utisca.edu echo. Next slide. Please join us for the next Texas session, which will be on a Thursday, August 31st, to continue the discussion on fentanyl. Next slide. And finally, our next session for Shout will be on Thursday, September 21st. Dr. Walker will be speaking that session. So please do join us. Thank you. And with that, we will move on to our case. Kato, if you could please pull up the case form, and Dr. Kapadia, you can take it away.
Okay, awesome. Hi, everybody. So if it's easier, I can also do it by a PowerPoint that I created, but it's just, whatever works well for the team. This case is not necessarily related directly to the talk that Dr. Weems just gave, but was a case that kind of stayed on our mind from our clinic that we have here with our residents. And so in full disclosure, I'm an outpatient physician, so I'm thinking about this from the outpatient perspective, but definitely, I think the inpatient perspective is really important to kind of put that cap on when we go through this. So this patient was in his 30s and presented to our hospital here after being hit by a motorcycle, and then after getting full body scanned, essentially suffered a right tib fib fracture. Per the description from the team in the hospital, and it was our surgery colleagues, that it was hit at 70 miles per hour. So, could definitely result in significant pain and clearly here a fracture. He didn't have any LOC, wasn't on any other medications, but at that time, he was kind of drowsy. So it was unclear what other medical conditions he had on admission. But later on through the chart, you would, and over time during that admission, was found to have opioid use disorder, anxiety, depression, and ADHD. His home medications that were listed at the time were methadone, 160, trazodone, 50, bupropion, lamotrigine, and buspirone. Though there was some history that he may have been on Vyvanse in the past as well for ADHD. In the hospital, they used the kind of pain protocol that's generally used, which consists of Tylenol. There were a couple doses of fentanyl. I think that was around like peri-procedurally, Dilaudid available, hydroxyzine, Zofran, Narcan, of course, and at starting on hospital day 2, they started his methadone back after reaching out to his clinic, and then Oxy 5, like the 2-step PRN dosing that was eventually increased to 10. In terms of social history, the patient was housed, and did not actively live with anyone who was using at that time, using any other substances. There's no relationship status reported, and to me, it's unclear that he had any children. In terms of employment, he was with a moving company a few weeks ago, and unclear if there was like some employment instability at that time. For support, the patient did report that he had really good sponsor support from his sponsored therapist. And he used bus for transportation, and there weren't any active kind of charges that I noted from a legal standpoint. From a psychiatric history perspective, history of anxiety, depression, and ADHD. Anxiety, depression, ADHD, potential history of PTSD that was later kind of potentially uncovered. So during his hospital course, he was admitted for a couple of days for acute surgical management for his traumatic right tib fib, and he was status postnatal stabilization. That was a surgery that they did. He was later discharged on Norco 40 tablets to take Q4 hours as needed, as well as aspirin for pain management. And his PMP was checked, and there was like multiple, maybe distant findings of Vyvanse. The most recent one was ketamine powder. And so kind of additional concerns So the way the case was brought to our attention on the outpatient side, he's followed up next day, and the patient had reported his pain was uncontrolled. And so because of that, he took all of his Norco tablets at once. And so he wasn't having any signs or symptoms of opioid overdose, but there was a concern for him taking several grams of Tylenol at that time. And so appropriately, the patient was then, so it was about 13 grams of Tylenol that was calculated, and it was an unintentional overdose. The patient was not reporting any suicidal ideation or anything like that. So the patient was then recommended to go back to the emergency department. So he was sent to the ED, where his LFTs were elevated to the 200s, 100, 200 range, and his Tylenol level was 27. The outpatient MAT team was then able to communicate with the evening hospitalist about the importance of increasing and kind of being more liberal with pain medications because of what had occurred on the outpatient setting. So he was started on an N-acetylcysteine, admitted to the internal medicine service there. During his time in the hospital, they did go up on the oxy to about 10 milligram two-step and then a 20 milligram two-step, but there was a concern of potentially hoarding the medications. And so then the patient was then de-escalated, and on discharge, had close follow-up with our MAT clinic, but was not discharged on any kind of opioid medications, but was discharged with gabapentin and recommendations to use ibuprofen and Tylenol as well for pain. So I know that was kind of like a long hospital inpatient outpatient course. It happened over about a week, I would say, and then he was followed multiple times outpatient in the addiction clinic. And so some of the questions that came up for us that I wanted to pose to all of y'all who are definitely experts in this field was how to think about addressing pain management for patients with OUD inpatient, and especially for patients with concomitant psychiatric disorders, which and potentially multiple medications I've been on in the past, and there can be some fears about substances that whether or not we're appropriately prescribing some of these controlled substances, including Vyvanse, potentially considering a model that allows us to more easily calculate doses of opioids in patient for pain. So thinking about pain pumps and what's the utility of that in both kind of giving patient autonomy while also getting like a more accurate understanding of how much pain medication that patient needs. And in addition to potentially like any MOUD they're already on, in this case, methadone. And then kind of another thought that came to mind, because I can understand that there's fears around prescribing too high doses for in both inpatient and outpatient. Can you think about what is like a maximum dose that we can even prescribe to patients with OUD? And then the last question, in this case, this patient had experienced Tylenol overdose. Thankfully, we were able to prevent acute liver failure with N-acetylcysteine. But is Norco a no-go for these patients, or how do we think about the use of Norco in terms of pain management on discharge? So those were some of the questions that came up from this case. So I'm curious to what the team thinks over here.
Thank you so much for that case presentation. And I'll open up the floor for any questions or comments. Lindsay.
Not a doctor, just so everybody knows. So I'm a peer specialist, and I would say that I very often see people who are, this is for outpatient, obviously, who are bored, honestly, and they can take too much medication because they're in pain, and they are in pain, but it's also because they're kind of sitting there doing nothing and they don't have anything to distract them. Peer specialists can be great for that. They can, get somebody out and about and kind of that holistic approach to it. That being said, if they're in pain, I don't know why you would prescribe painkillers, because for me, I see a lot of doctors that are hesitant to prescribe these things, but then somebody's going to go use on the streets and die. So, I always think it's better to know what you're taking than, potentially need to go to the streets for something else. But yeah, I mean, just having somebody there to talk to and to distract you, I think is very helpful.
Thank you.
I-
Dr. Miram, sorry, Dr. Weems, go ahead.
I just want to echo Lindsay. I think that's such a great point. It's a team sport, and when you're on a team or an environment where you do have a peer or another team member who can be with a patient, help sort out sort of what's going on, it can make all the difference. And then I think you made a point that's pretty straightforward. If somebody's in pain, they might need pain medicines. And I think when I hear this case, that's what really sticks out. It's like, here's a person with a very severe injury who clearly it merited treatment with opioid analgesias, and then there's a lot of challenges and learning opportunities in how that therapy was started. So I just want to absolutely, and from the medical perspective, yeah, this person was appropriate for opioids. And echo that.
Thank
David,
you.
Yeah.
Dr. Miramontes.
So when I hear this case, it just pains me because we had so many opportunities to help this patient in his acute need for pain management. So in my look at this, he should have been loaded with gabapentin in the OR. They should have given him a gram of Tylenol in the OR. The surgeon should have thought about long-acting local pain management, the 3-day bupivacaine suspension. Anesthesia could have done a nerve block for a couple days of pain management. Why wasn't he on a PCA pump at high dose? Why wasn't he given methadone the first on admission to make sure his tolerance level is not maintained? I think we failed him in many ways in his impossible treatment. And 40 pills of Percocet on discharge with a patient who has their pain out of control, it's a little problematic for me as well. So I think we failed this patient by not giving him the tools that he needed to really manage his pain up front. And then afterwards, so this guy got a nail in his tib bib, right? Horrible pain. He's going to need agonists, right? And I think we didn't address the level of his discomfort. He was branded as a drug addict and didn't get his meds. This just pains me to see that we had opportunities. Perhaps our colleagues in anesthesia could have stepped up to the plate. PCA pump would have been a great idea for this guy, knowing that he's going to require a larger dose, a significantly larger dose for his basal hourly rate. And he may need an increase in his push dosing every 15 minutes. So getting anesthesia and pharmacy involved early to say, hey, this guy has a high tolerance for opioids and he has a very high pain issue. Let's be aggressive.
Thank you so much.
I'll echo that, Dr. Mayer. I think that there were so many missed opportunities. I think one way of hearing this case is, for folks to say, well, this is the problem with prescribing opioids for patients with opioid addiction, which would be the exact opposite lesson, right? The lesson's everything you said, like we have to use a multimodal approach, be aggressive up front. And there was a recent study that came out of Boston and JAMA looking at the use of intraoperative opioids. So along with a multimodal approach, but patients who had higher doses of fentanyl and Dilaudid in the operating room had lower post-op pain scores immediately post-op, which makes sense. And they had lower incidences of new onset chronic pain for months. And so when we're aggressive up front, you avoid post-op complications. And one of the post-op complications Dr. Kapadia strikes me about this case is a potential Tylenol overdose. I mean, we failed to get ahead of it up front, and it resulted in potential harm to the patient. I put the link to the study in the chat, and that's not directly applicable because this did not look at folks with opioid use disorder. But I'm curious, Dr. Walker, anybody in Travis County who's got a post-op patient struggling puts up their Walker bat signal to try to figure out how to set up a PCA. I'm curious how you would have thought about this case as they came out of the OR.
I just agree with everything that's already been said. I think the struggle, 'cause I mean, I know of this case. Heard about it after. I think, really big struggle in our hospital systems is trying to engage our colleague surgeons, orthopedists, orthopedic surgeons, anesthesiologists to learn this stuff and to actually engage in more patient-centered, nuanced, appropriate pain management. And I think the struggle is like, it depends on where you are, like sort of the culture of, let's get somebody else to do that. Is there someone else? And then when you don't have that available, you don't have a readily available B team person to help. You don't have a readily available pain option. You don't have an actual like anesthesia pain service. And I think it gets hard. And I agree. Like, I think that was a big fail. I also think for that patient in particular, like he's demonstrated, and he overdosed and got toxic on Tylenol. Like I think it's a good idea to know you are giving some opioids to a patient who may overtake their medicines. They have an opioid use disorder. It's not necessarily inappropriate if you could treat their pain appropriately and they're actually doing okay and they've been there for a few more days. It's not necessarily inappropriate, but maybe don't include Tylenol in the combo product. Let's do that separate so that, it's not, you're adding, you're just adding extra danger for that patient. I don't know, but I think it's hard. I think we're also always balancing. So in that particular environment, that's at 200% capacity all the time. There is a lot of pressure. You're not needing to be here, off you go. There's a lot of pressure to kind of move on, but I totally agree with everything that was said. And I think that we got to be aggressive from the beginning, and we need some partnership with, our colleagues that kind of appreciate big tolerance. Go big or go home, and like give the guy a couple extra days. Let's make sure so that this doesn't happen, because it would have avoided the readmission Tylenol toxicity. I don't know. So, but I think it's a great case. I think it's great, like, here's the case that we can bring to all of our colleagues. Anyway, go ahead, Dr. Ramiro-Montes. Sorry about that.
I was just going to say, you brought out the point I was going to try and make is, let's uncouple the Tylenol and the narcotic. Uncouple them. That way, this guy's going to get a gram every 6 hours. We're going to maximize the analgesic effect of the Tylenol and give him Dilaudid by himself. Give him 2 4-milligram tablets, and he takes those on top of his methadone that he's daily taking. But I think we get into this habit, and our orthopedic partners and our ER partners do this all the time. Norco 5/325, just knock it off. Uncouple, give maximal Tylenol, give maximal opioid as they need it, and just be done with it. Uncouple the two drugs, because they work differently, and we're not doing a good job of maximizing the Tylenol for it's coupled with a narcotic.
Yeah. And what's interesting is that in that particular hospital system, they're uncoupled in the hospital. Nobody uses hydrocodone in the hospital. We only have it available with Tylenol. So it's not part of our pain protocol. And the pain protocol includes Tylenol, a gram, with max 4, and they do that. And they schedule in so that if you need it. So it's interesting. It was a deliberate choice to discharge him on Norco, which I think again highlights kind of a discomfort in some cultures of prescribing the opioid at all. And I think there's a perception, and it may be regional, I don't know, but like this perception that like maybe Norco isn't as bad as oral hydromorphone or oral oxy. And I mean, they're all opioids. So it's not, and again, I think there's just sort of this perception, okay, we'll give you this is probably the least worst. And I think that's where all that, it's just like, it's like Swiss cheese holes in culture, like lined up to be perfect storm of whoops, and ends up being a really great teaching case and example to bring back to colleagues and like circle the wagons of this can be done better. Let's do better.
Couldn't agree more. And the only two worse options would have been T3s or tramadol. Because tramadol overdose like this would be could potentially be a long ICU stay if he made it there. Like tramadol and overdose is a toxicologic disaster. And that's another, it gets to that point, right, Dr. Walker, like the people are in the habit of perceiving things as being lower risk without looking at the patient in front of them and realizing you got to go big. And if you're doing opioids, sort of trying to mitigate that risk with either tramadol or T3s or prescription of narcos, say first, kind of not getting.
But yeah, I mean, tramadol disaster, but the Tylenol, thank goodness he was caught fast. I mean, I'm a psychiatrist, so I see Tylenol overdoses and people dying of fulminant liver failure all the time. Thank goodness he was found so fast and got on a NAC protocol. The N-acetylcysteine, for those of you all who don't know what I'm saying, like the antidote protocol for Tylenol overdose, because people die from that. And it's usually a terrible death. It was a great case.
I recently discovered a really big systemic problem, and you should look at your own hospital. So in my teaching hospital, residents are only allowed to prescribe Schedule 3 narcotics. So they're not allowed to prescribe the Norco, Dilaudid, hydromorphone pills. An attending has to do that. What kind of stupidity is that? So now we're setting them up to giving them T3s and tramadol as a matter of course, because it's easy and they don't have to bug the attending, when it's the wrong answer. First of all, those drugs are terrible for orthopedic fractures, like in this case, right? Those are bad drugs for that. And so we've set it up our residents for failure and our patients up for failure by our systemic restrictions.
Yeah. Well, but so my question is, how are you overcoming that? Because isn't it because they don't have their individual license yet, so they can't have DEA Schedule 2 prescription? Like it has to be an attending, or is that just something that's that was my understanding, is that it's a DEA rule. That's not true.
No, because every resident has a hospital training license and the hospital's restricted to Schedule 3s.
Oh, so you're talking about ordering in the hospital,
Yeah.
not the prescription outside.
Right.
Is
Well,
the
even
prescription, but am I reading the prescription leaving is still, you have to have your own individual, right? DEA doesn't allow residents to prescribe Schedule 2s. Do we have any
No.
pharmacists on here by chance? I'm going to find out.
I think it's a
I should find
hospital issue, because I'm bringing this up with my organization right now.
Because that is our culture for the prescription.
Right.
And so then, there's this added tension of let's do something else so they're on it already when they go. Not
We're
the
setting-
ordering, but just the prescription.
We're setting ourselves up for failure.
That's true. I'm going to bring up a point from the chat Dr. Chin made. He's noting that he often finds it hard to know how opioid tolerant patients are, especially on methadone. He's wondering, do I use oxycodone 10 to 20 or maybe Dilaudid 4 to 8? Typically uses those rather than hydrocodone morphine in patients known to be tolerant. Curious people's response. My sense is, Dr. Chen, well, one point, you and Dr. Walker both do a great job of being available to other teams, so if they need you, and so your educational mission helps get to a point Blair made earlier about like, it's if these teams have an opportunity to learn this stuff, so we have a systems-based approach to improving care. That's one thing for Dr. Chen. The second one is, I like how you put ranges, and the other, you don't know. You're big. You're in the big leagues if somebody's on 160 of methadone. And if they're on 24 bup, you're in the big leagues. And so starting around those doses and with a range and frequent reassessment and finding out where you are. If you start out with oral protocol, I think the other strategy is one Dr. Walker uses often is using that PCA pump. Curious what your thoughts are, Blair. Dr. Walker.
Agreed.
Thank you so much. This has been a very, very engaging session. Dr. Weems, if you could please give us a quick summary of today's discussion.
This is a great teaching case presented by in her inaugural presentation in the Shout Echo with Dr. Kapadia that really brought to light many opportunities for addressing pain in our patients with opioid use disorder, since we know that untreated pain is a way bigger trigger to use more dangerous drugs, as Lindsay pointed out, on the street and decompensate people's stability. A systems approach might address deficits in educational and culture around prescribing. Those are the 2 takeaway points I got. Thanks, everybody.
Thank you so much. And thank you all for joining today's Shout Echo. As a reminder to NCE credits, please text the activity code 100-94250 to 844-502-1338 by midnight today. We also request you to complete the post-session feedback survey using the link in the chat. The survey link will be open for 1 week. If you'd like to present a case, please email bveltx@uthsca.edu. We look forward to seeing you at our next session on Thursday, September 21st. Have a wonderful rest of your day. Bye-bye.